You're listening to the Smart Policy Podcast, a production of the University of Tennessee's Institute for Public Service. West Virginia has often been described as ground zero of the opioid epidemic, largely because of the explicit targeting of the state by Purdue Pharma for its aggressive marketing of OxyContin. First responder Jan Rader, longtime champion in the fight against the overdose crisis and the first woman to serve as fire chief in West Virginia, disagrees. At the 2025 Syndemic Summit held in Huntington, she said to the crowd, "We were just the first to talk about it."
You know, our mayor at the time, Steve Williams, amazing leader, he actually took action and bold action and innovative action that had not been taken before. And he created at a city level of 46,000 people an Office of Drug Control Policy. Figure out how we can make positive change with what we're dealing with. How can we stop this? How can we combat this?
In this conversation, we discuss why naloxone remains important even as new drugs like medetomidine are found across the country.
When you have an opiate on board, you have the possibility of death within 5 minutes if you don't reverse that. You know, your policy goes down, okay, we deal with the most life-threatening first, just like a triage situation. I think we certainly need to keep our foot on the gas with naloxone.
How the importance of mental health for first responders is growing exponentially.
They weren't just going to overdoses. They were going to overdoses of their friends, their classmates, sometimes even a family member. And the burden was just so heavy.
And the policy issues that keep us from adapting to shifting drug trends.
I think that one of the things that I have seen over my 30-plus year career so far is a lack of flexibility of policy.
Among other topics.
There's anoxic brain injuries out there, and I think that a lot of those anoxic brain injuries we're not treating, and we're not even recognizing them as a part of the disease process itself. My name is Jan Rader. I am currently the I am senior advisor to Mayor Patrick Farrell in the city of Huntington. I have worked for the city for 31 years. 27 and a half years of that was with the fire department. At the end of my career with the fire department, I was the fire chief for the last 5 years.
What made you want to be a fire chief in the first place?
I don't know if I really ever wanted to be a fire chief, but I actually became interested in the fire service because I was working in the jewelry business. And a lady had a heart attack close to the doorway of the store where I was working, and I felt helpless because I didn't even know CPR. So I called 911, stayed on the phone. Some people stopped and did CPR on her, and then the fire department showed up, and there was a woman firefighter, and this was in the early 90s, and I didn't even know that was a choice back then. So I was a big runner, and I ran with some firefighters, and I mentioned it, and they said, "Oh, yeah, this would be good for you." And so that's how I got into firefighting.
You know, I've heard similar stories across anybody who works in public health, healthcare, any public serving, especially with a health component or a saving lives component, that, some sort of lead by example thing. Do you consider yourself leading by example as well?
I hope so. I don't know if that's for me to determine.
That's fair.
So.
Well, I was just at a conference where a couple hundred people seem to think so.
Okay. Yeah. Well, you probably spoke with them more than I did. So.
Well, so if you don't mind me asking, I understand Time named you as one of the most influential people.
Oh, yes. 2018? 2018? Yes.
Yeah, I mean, that's pretty substantial. What was the... What was their reasoning behind that?
I'm really not sure. I think it's our fight against the opioid epidemic here in Huntington, West Virginia, and it was right after the release of the short documentary Heroin that was released in September of 2017 that Netflix put out, and it kind of went viral, and I think that probably had something to do with it.
You know, you said something at the reception at the Syndemic Summit we were just at, that you don't necessarily see West Virginia as ground zero. You see it as the first place to talk about it.
Yes.
Yeah, I'd like to learn more about that.
So, yes, we've been called by the media across the country over and over again ground zero for the opioid epidemic, but I really do feel like this was going on in many different places. We were the first willing to talk openly about it and to try to draw attention to it because we felt like we needed help with what we were dealing with and what we were seeing. Our mayor at the time, Steve Williams, amazing leader, he actually took action and bold action and innovative action that had not been taken before. And he created, at a city level of 46,000 people, he created an Office of Drug Control Policy. And he asked me to serve on that. At the time, I was a fire captain. And I'm also a registered nurse. So I was working on my days off at one of the local emergency rooms. And he knew this because several times his parents who were elderly were brought to the emergency room in the middle of the night, and there I was, so he knew he had somebody with a medical background that worked for the city. And so he took a retired police chief and asked him to stay and be director of the local Office of Drug Control Policy. He asked me to serve on this, and he added the crime analyst for our police department. And we were three incredibly different people from three different backgrounds, and put us together, and we were like, what do you want us to do? And he's like, figure out how we can make positive change with what we're dealing with. How can we stop this? How can we combat this? And we took off in three different directions. We all, between the three of us, we pretty much knew everybody in town. And we started talking to people on the front lines, and more heads are better than one. What do you think needs to happen? I went to the health department. One of the first places I went and talked to the health department nurses, and said, what are you seeing? You're on the front lines. What do you think needs to happen? We talked to police officers. We talked to firefighters. We talked to people working in homeless services. We talked to our healthcare providers. We talked to our libraries. We talked to many different areas. And it was perfectly clear that we needed to do things like open a syringe exchange program. So we did that. We started the first syringe exchange program in the state of West Virginia. It opened September 2nd of 2015. We knew we had to get naloxone in the hands of all our first responders. It wasn't just okay for EMS workers to have it. And at the time, there was legislation that said that you had to have special training before you could have it. My friend Joe Murphy and his wife Susan, they were instrumental in helping us in that plight and getting around education, providing education very quickly so that people, just everyday people, can learn how to use naloxone and give it out. So by the time we had the first big batch of fentanyl come through our town, all our first responders, police officers, firefighters, EMS workers had naloxone. We had an event, it was actually August 15th of 2016, where we had 26 people overdose in less than a 5-hour period. And we saved every one of them because our first responders had naloxone. Now, we had a very big lesson that day. The first lesson was nobody was referred to treatment. And that was the piece that we had not focused on yet. And so people who survived that event died in the next couple months because they couldn't get into treatment, were put on waiting lists, things like that. We needed to expand services. Another big lesson from that was our emergency rooms. We have 2 level 2 trauma centers. We're not testing for fentanyl. So nobody that day tested positive for an opiate because in the panel at that time, they were not testing for fentanyl.
Right.
So, there was a study done on that event, and these events had happened around the country, but and many cities who experienced them lost a lot of people. We did not lose people in that event, during that event, because we had thought about it and tried to prepare. We've been able, because we're small, and partnerships and collaborations create a lot of innovative ideas. We had leadership that was willing to support ideas that we gave them. We were not afraid of failure. We felt like if we failed, so what? We're going to learn more from it, and we're going to turn around and punt and find a different way. We started, both our emergency rooms were packed with people with overdoses, and it was very arduous to deal with, and they did not have a system of referring people out. So we got all the partners together, and they came up with, and competitors, medical competitors, went together and started a freestanding facility where people can go that ask for help. It's called PROACT, and don't ask me what it stands for because I can't remember. But they can go and be plugged into a system within two hours to get the assistance they need. We have Project Hope is probably another extremely innovative program where a mother can get intensive inpatient therapy and keep her children with her. Even if she's pregnant, they'll help her with the pregnancy. They'll get her through the pregnancy. This is a facility with 17 apartments where women can live with their children. They have intensive therapy. The program is 6 months long. They have a step-down apartment afterwards. It is breaking the generational cycle of addiction.
Yeah.
It is breaking the cycle of poverty, and it is transforming lives. So in Huntington, we have been able to do so because we had bold leaders. We still have bold leaders. I'm working for my 5th mayor now, and he's amazing too. But we have bold leaders that have been willing to take chances.
Yeah, there's so many things you touched on that I'd like to follow up on.
Sorry about that.
No. Don't apologize. These are excellent points of discussion. I think. I think first and foremost, thinking about Project Hope, the notion that a pregnant patient can keep her kids while receiving treatment. In Tennessee, we for a while had a law that essentially criminalized being pregnant and addicted at the same time. And it led to a lot of people foregoing prenatal care altogether because if they were detected as having a substance use disorder and being pregnant, if they weren't connected to treatment, which in and of itself is difficult and inaccessible for some people.
Absolutely.
Especially once you add on that a lot of clinics don't want pregnant patients because it turns out there's a lot of complications and all sorts of things. But on top of that baseline difficulty, if they didn't get into treatment and establish it within a set time frame, they were liable for a crime and could go to jail. And so a lot of people were just avoiding treatment. That law died. It was called the Fetal Assault Bill.
That's unfortunate that even existed.
People still think it's around. It left a stigma landscape.
Absolutely.
Was it related to this and with the syringe exchanges? You said Huntington was the first to have one. We had to pass a law to legalize them in Tennessee. Was a similar situation?
We did too. We had actually what syringes were listed as drug paraphernalia.
Right.
So we took care of that at the state legislative level. Now we're moving into a different time frame politically where, they might not continue to exist.
Right.
And that's unfortunate because you do have the spread of bloodborne pathogens when there's needle sharing and reusing, and you have people with severe infections becoming septic, vegetation on their heart valves from endocarditis, so there are a lot of medical complications from IV drug use, especially if they do not have access to clean needles. So, it's just going to be interesting to see where we go from here.
Is there anything you'd like to say in terms of other than you just laid out some excellent evidence behind why SSPs are a good strategy?
I stay in my lane. I'm not a politician, nor do I aspire to be a politician. I follow science and I follow humanity. First and foremost, I'm a humanitarian, and I think that we are here to support and uplift each other.
Gotcha. The drug paraphernalia angle in terms of legislative coding and the like, fentanyl test strips was another similar policy that's been.
We had to address that as well.
Yeah, same in Tennessee, but
then xylazine.
And now soon to be medetomidine. And,
we have those test strips now, and actually, we have had clients share with us that their product is testing positive not only xylazine but for medetomidine.
Yeah, I believe that was in a recent. We won't get into details, but there's been a lot of talk of medetomidine across the country. On that same notion, though, I wanted to commend West Virginia we did some research into drug paraphernalia laws. West Virginia did a blanket decriminalization of testing strips regardless of substance. Do you feel that that enables West Virginia to be more adaptive to shifting drug trends?
I hope so. I would hope so, and I would hope we would continue. You know, I think one of the problems that I have seen, and, you know, I've kind of watched all this unfold. I've watched us, you know, go from pills to heroin to fentanyl to xylazine and whatever's next, meth, you know, you name it. And it's all polysynthetic now. And, you know, drug dealers have a fabulous business model. They're not going to give it up. You know, they're going to keep making money. And as long as we have people that are suffering, they're going to be rolling in the dough. So I think that one of the things that I have seen over my 30 plus year career so far is a lack of flexibility of policy to deal with those trends. For instance, some of the policy that was developed during heroin time frame did not allow for the switch to other medication. You know, when we had built programs to deal with opioid use disorder and then the product became methamphetamines, then we did not have the ability to use those funds for a changing drug market and that we have no control over. So I think that's probably my biggest takeaway is we need to be more flexible with our policy moving forward because we don't know what's on the horizon.
Which do you think is a more concerning threat? And this is a tough question, I may understand, because not to downplay lethality of any particular substance, but we are paying a lot of attention to opioids.
Yes.
We also have quite a number of tools at our disposal. It might be a pointless question because I don't know if I want to differentiate in the context of polysubstance use, but in terms of opioids versus stimulants, perhaps, I might say, what are some challenges we should keep in mind? I don't know if I want to pit them against each other.
I think they're very different creatures, and we should not pit them against each other, but we got to take them on face value. When you have an opiate on board, you have the possibility of death within 5 minutes if you don't reverse that.
Yeah.
That is something that you don't have to deal with stimulants. Okay, you have other medical issues as well as behavioral issues that you need to address, but the majority of the time they are not life-threatening within the next 5 minutes.
Right.
So I think we certainly need to keep our foot on the gas with naloxone, and I think they're very different creatures.
Right.
You know, but they're all mixed together. And you don't know what's in that concoction. Yeah. So, you know, your policy goes down, you know, okay, we deal with the most life-threatening first, just like a triage situation in an emergency room. Triage first, okay? ABC, airway, breathing, circulation. So I think you can develop those patterns or what you should do regardless of what substance you're dealing with, you know. And I feel very fortunate to be in an area where they took us seriously when we said, naloxone, we need this. My buddy Joe Murphy created something called a one box to get around the education needed before you can give naloxone or give out naloxone to somebody. And then right after he developed this one box, and it's basically like an AED. It walks you through how to give naloxone in case you forget, you freeze in an emergency. You just open it up and a video plays guiding you through how to give this. And that was so innovative at the time. And then it turned to over the counter. But it still has so much importance to it, the one box, and there's all kinds of duplicates out there now, but my buddy Joe was the number one guy. He's just awesome. And it's near and dear to his heart because he'd been working on this for over a decade. You know, he tried an app first and, you know, all kinds of stuff. But I feel like the average person, you know, I'm somebody who's jumped on a fire truck and run to emergencies for years, but the average person, you can teach them CPR, you can teach them how to give naloxone, but in the moment of the emergency, they're going to forget and freeze because that's something new first responders have to get over. So if you have a device that walks you through it, I mean, that's key. You can save the life of a loved one, a stranger, And in the moment, you're saving their life in the moment. And saving their life in that moment gives that person an opportunity to choose a different path, to get to the treatment facility that they need, to get the help to change their life.
Yeah.
So, I don't even know if I answered your question, Jeremy.
No, this was just great. And I was going to say we have partnered with West Virginia Drug Intervention Institute, the maker of the One Box, Gibson Gives, and then various city authorities, Metro Nashville Police Department, Chattanooga Police Department.
Saving lives.
Yeah, drug coalitions, exactly. And
Saving lives.
One of the managers we're in, we installed a One Box. This is one of the music venues in one of our cities we've worked on. He showed me the security footage. We covered this in an earlier episode of an employee using the box to reverse the opioid overdose. And 5 minutes later, the EMTs were able to arrive.
It's
but
so
it's
cool.
like 5 minutes, like you just said.
5 minutes is a long time.
Make or break.
Well, here's the other thing that we never discuss. And, I still work on the front lines. I work on homelessness, substance use disorder, and severe mental illness for my city. And I'm trying to facilitate expansion of services and better pathways of how we can all work together to do better for our citizens and to make it safer for all of us. But one of my best friends is a physician in town, and she works with homeless individuals. She provides free medical care to homeless individuals, and she works for a place called Valley Health Systems, and they're amazing too. They're an FQHC, and they believe in dignity and non-biased treatment of everybody. But we talk about all the time the fact that we deal with people who are in long-term recovery, and they have effects of going without oxygen for 3 minutes or however long they were gone. I on a regular basis, I work with people who have overdosed themselves. Now they're clean, but there's anoxic brain injuries out there, and I think that a lot of those anoxic brain injuries we're not treating, and we're not even recognizing them as a part of the disease process itself. And that, to me, is another reason why naloxone has to be out there everywhere. Just flood the freaking United States with naloxone. Because even 2.5 minutes without oxygen, you're going to have some damage.
Yeah. Yeah, I wonder if you spoke with him about this. The writer Sam Quinones mentioned this.
I have not spoken to Sam. I've met Sam a couple times. He's come to Huntington. I have not specifically talked to him about it, but Dr. McElroy, Sidney McElroy, and I talk about it on a regular basis, and we have for years. Because we're so busy keeping people alive that you can't get down into the meat and potatoes all the time.
Right. And for those listening that don't have a medical background, anoxic brain injury is when the brain itself is deprived of oxygen for a sufficient amount of time that there is still tissue death.
Yes, you can have, you have short-term memory loss. You can have long-term memory loss. You can, so...
Behavioral changes. You
can have impulsivity changes, frontal lobe damage. There are a lot of things that you can have. I mean, I'm certainly not an expert on it, but I see it.
Yeah.
And I always wonder about that because I don't know each individual's background, and what they went through. But I think it's something we need to address at some point.
Yeah, certainly. It's a valid concern because, we already have baseline difficulties with making sure people have stable housing, workforce training opportunities, continuing adult education, on and on. In this notion of just so many different pieces of the puzzle, the city having an Office of Drug Control Policy is really still unique. I think it was Pew who just came out. It was either Pew or Rand who came out with an analysis of presence or absence of Office of National Drug Control Policy. Could have been LAPA as well. I can't recall. And not every state has one, let alone a city. Sure. That's rather innovative.
Well, we had it for a little while, and then we let it go because, we felt like our partners had, I can't remember when it kind of basically just dissolved, but, we felt like our partners and everybody, we were all working so well together that we all went on to different areas. So it just kind of organically dissolved, and then COVID hit, and of course that changes everybody's focus. It becomes you work with your own organization and how you survive there. And then as we emerge from that, but I will say this, after the city of Huntington developed an Office of Drug Control policy, the state of West Virginia followed, and they had an Office of Drug Control policy, and our state has had one ever since.
Yeah. Yeah. And you mentioned COVID. Yeah, we've seen similar efforts in Tennessee at local levels. There's a Knox County, Knoxville City jointly operated things called All for Knox, Health Department, Medical Examiner, on and on, all breaking down data silos and the like. Hopping up to the state, you think probably added some some protection against the COVID effect?
Absolutely. Currently our state director of Office of Drug Control Policy is Dr. Stephen Lloyd.
Right.
And he's phenomenal. He's a Tennessee boy.
Very fond of him.
Yeah, he actually likes to wear a Tennessee hat.
Is that getting him in trouble?
No, I don't think so. He's been wearing other hats here lately. But,
definitely.
But he's such a knowledgeable, incredible leader. I really enjoy him.
Yeah, we do too down Tennessee.
I bet you do.
No lie.
He's shared between states as I see it.
I don't know. He has the energy for it. It's really impressive. Something you had said near the beginning of this really stuck out with me. I was working on my day off. When you were talking about working in the ER.
Oh, yes.
Because you're an RN. So I was working in the ER on my day off. You didn't even realize you had said it, but it's an interesting phrase. And I was wondering if you could speak to the notion of public service.
Well, I was a paramedic for years, and I used to work on my days off from the fire department as a paramedic. They don't pay firefighters as much as other jobs, and so as I got older, I thought, well, I need to do something a little more stable. So I went to nursing school, at age 40, and then started working in the emergency room. And, I feel like we are here to serve others. I don't feel like I'm a helper. I'm not a fixer. I'm a servant to my community.
Beautifully put.
I feel like I have a servant heart, and I'm not above anybody. I'm not below anybody, but I'm here to serve when I can. We don't cause these emergencies, but we're here to try to make them a little better and maybe ease the pain just a little bit.
Very well said. The ER is a rare place, a very unique place.
It can be.
I won't get on the full moon effect. But what do you think the average person doesn't understand about emergency medicine? Even beyond just the overdose crisis, which is definitely a factor, but it's a different place.
It's a very chaotic, just like a fire scene. People look at it and they think, oh my God, that's chaotic and it's crazy. But we know exactly what we're doing, what we're supposed to do, and we orchestrate it very well. We just go into a mode and do our thing. It's kind of like a dance. We know each other's strengths and weaknesses. If one nurse is dealing with a patient who vomited and that nurse can't deal with vomit, the rest of us rush in and clean up the patient for that nurse. And, it's vice versa, if it's another bodily fluid involved, that another nurse, so we, it becomes like a giant family where you take care of each other, you have each other's backs. And it's a very unique place to work. It's very fast-paced.
Yeah, no kidding. Feast or famine.
Yes.
Yeah, no kidding. I thank you for giving such a humanizing story.
Sorry about that.
No, we'll call it emetophobia. I used to work with a physician myself, and I recall there was he really could not stand the sight of vomit. Tremendous physician, and I'll just remember one day where we didn't have a backup nurse who could do it for him, but he needed to personally see what the contents of the vomit was. Is there blood? Is it coffee grounds?
Sure.
The whole. I just quick. All right, I'm done. I just
absolutely.
Let's get out of here. They're people. They're people.
We're people. We all have quirks and things that bother us. We're not very good at taking care of ourselves. No. We're very good at taking care of other people. It's probably a trait that most people have in this business.
I would say so. This is something we've talked about before with a number of our guests in the past. How big a problem is compassion fatigue right now amongst public servants?
I think it's up there, but I think it's really empathy fatigue versus compassion fatigue. And, other people can explain that better than I can. But I will say this. I think that we as, like in Huntington, we're trying to fix that with our first responders. We started a program in 2018. We got a Bloomberg grant. I think we didn't start the program until 2019. We won a Mayor's Challenge Bloomberg grant, and we decided to tackle compassion fatigue for our first responders. The city runs police and fire protection. The county runs EMS. So we focused on our police and fire department, and we built a program called Compass Navigating Wellness, and we're trying to normalize seeking out mental health services when you need that. We are trying to make sure that our first responders take better care of themselves, and when they retire, they are a whole person, body, mind, and soul, versus being somewhat broken with PTSD and other things. In my career at the fire department, 27 and a half years, there were 3 suicides. Oh, my God. And 2 when I was younger on the job, and 1 while I was a chief. And I don't want anybody to go through that. It's heartbreaking. It's heart-wrenching. So, we take that seriously. We want to normalize seeking out mental health therapy. Just like you go to your doctor and get a checkup once a year, you should check in with a therapist, every so often. Yeah. So I think police, fire, EMS, we're supposed to be the Caped Crusaders, and nothing bothers us, and that's bullshit. Yeah. Because everything has the tendency or can bother you. It just depends on, we have our own lives. We have things going on with our families. And so we're not immune from any of the things that other people see. But one of the reasons why we went down this road of trying to develop a program for our first responders was because, our young people on our job, they weren't just going to overdoses. They were going to overdoses of their friends, their classmates, sometimes even a family member. And the burden was just so heavy. Our number of calls increased. And, there's more of a focus on them. It's it can be a very negative. Overdose in itself is an incredibly negative event. Yeah. It's negative for the responder. It's negative for the person who overdoses. The only positive is you use a drug to reverse the overdose and you save their life in the moment. They might cuss you and run off, right. But I'll take a cussing over a dead body any day. I don't care. Yeah. But it's not a lighthearted event, and when you go on these over and over again, it can be very problematic if you're not equipped. Resiliency, we do a lot of mindfulness training. I've become a mindfulness coach. We're trying to change the way we do business with our first responders in Huntington. We're giving them more attention. Yeah. I had a craziest thing. I'm pretty compassionate, but I had a firefighter look at me with a tear in his eye, and he said, "You love addicts more than you love us, Chief." Whoa. And it was like a dagger through my heart. It wasn't true, but the perception was there. Yeah. And it really changed the way that I interacted with my first responders. Fascinating. Yeah. Weird shit, huh?
Very real, though.
Very real. Very real.
Do you have any advice for fire chiefs across the country for navigating situations like this, to both be compassionate to? Because right now, a lot of first responders are burned out on helping what they see as the frequent flyers. I've already overdosed this person 5-6 times. I'm tired of responding to this person. We hear stories about this kind of thing. Right.
I get it. You know what? We have to be willing to listen to the front line and take their advice and ask them, what do they need? What do you need? What can I do for you? that's how my mindset changed when I started working as a nurse. I saw so many people that would be run off by other medical staff, and it's like they didn't want to deal with the difficulty. I mean, a lot of people suffering from substance use disorder are very difficult to handle. And, I wasn't taught a lot in nursing school about what we're dealing with, but, I just got frustrated with it, and I started, asking my patients, I'm like, look, what? I don't understand. Please, I'm not being mean. I'm not being judgmental. I want to understand how I can help you. And I want to understand how you got to where you are. And please tell me what I do that makes this more difficult for you. And what is it I can do for you that will make your situation better? And just having those humanistic, compassionate conversations changed how I treated my patients.
Yeah, and in that same vein, you mentioned something about the younger generation having an especially difficult time entering this line of work because they're so often responding to people they grew up with. Mm-hmm. And that's just, it seems like the weight of the numbers about when this epidemic hit and what age groups and the like. Do you have any advice particularly for Gen Zers who are looking at becoming a firefighter or a police officer or nurse or a doctor or anybody on these front lines?
I think you need to research your area. I mean, it's different in every area of the country, you know. Just do your research. There's a lot of older people in the profession that are willing to talk openly about what to expect. I mean, and for all the negativity that I'm sharing with you, there are so many positives. When I walk down the street and I see somebody that just 5 years ago I probably revived with naloxone a couple times, and they are clean and they have a great job and they're back in college seeking out a degree and they're thriving and they're grateful for a community that helped them survive what they went through. That's more than any thanks anybody could ever give me. And I see that every day. And so I think another thing that we need to do is share the positives versus just negative. And there's so many stories out there.
Yeah, at the RX Summit most recently, for the first time, they had a wall of hope. Mm-hmm. Whereas they used to display pictures of everybody who had overdosed. Now they were showing pictures of everybody who had entered recovery. So it does seem an important tone shift these days.
Absolutely.
Yeah. Our final question is always, what policies should we consider at the federal, state, or even local level to make this fight better? That's about the usual response I get.
Oh, yes. Have you read the book Chasing the Scream?
Oh, Johan Hari.
Oh, yeah.
Tremendous.
I think he probably nailed it.
Okay.
I don't know if we're going to see that. I think that I will just end by saying this. We can't make leaders change their minds any more than we can get somebody who's suffering from substance use disorder to change their mind they got to figure that out for themselves.
Right.
And I think that's very important. So I think we support each other, we share education, we share what we've learned on the front lines, and that's how we move forward, and people will figure it out. And I encourage certain books. I think all leaders should read the book Compassionomics. Stephen Treziak and Anthony, begins with an M, can't remember. But it's a book that systematically proves that compassion is the way through this. Better outcomes for your patients, better work environment for your healthcare workers, and the bottom line goes up. Everybody does better. I think compassion is the way out of this, not this divisiveness or violence. And I think that as a country, we need to share with each other. We need to have hard conversations and just put the information out there for people to figure it out.
Man, beautifully said. All right, Jan Rader, thank you so much for joining us on the Smart Policy Podcast.
You're quite welcome.
Really appreciate it.
Quite welcome.
For more episodes on in-depth discussions on Tennessee policies related to substance use disorder by a range of local experts, please subscribe to us wherever you get podcasts and visit our website at smart.tennessee.edu.
I'm Jeremy Corvelis. Thank you for listening, and see you next month.